Welcome back, everyone, and thank you for the Ask the Experts, and thank you for joining us for Ask the Experts Session 2 at this year's OCRA conference. Again, I'm joined by my friends and esteemed colleagues, Ronnie Alvarez from Vanderbilt University and Anil Sood from MD Anderson Cancer Center. Thank you guys for hanging around and joining us for the second session.
Thanks for having us.
Yeah, thank you.
In our first session, we discussed some new cutting-edge therapies. And we're all excited that patients have gotten to live longer with ovarian cancer, but it's much more complicated than that. Living with ovarian cancer includes fear, includes constant treatments, includes managing side effects, and impacts your family and those around you. And you were very brave in sending in questions with regards to how to live your best life despite having ovarian cancer. And having that important relationship with your physician is very important. And I think each of us are, I know we're all compassionate physicians, but we probably approach things a bit differently. Ronnie, do you want to just talk a bit about your approach to a patient at her third recurrence, perhaps, and discussing her future and living with her ovarian cancer at that point in time?
Thanks, Beth. I think, first of all, it's important that, to think back 20 or 30 years ago when we really didn't have much to offer to patients after frontline therapy. And so to see patients that live longer, particularly with some of the newer treatments that we talked about in the first session, is really an enormous, blessing for our patients and blessing for us as the people that are providing this care. I try to work with patients to understand where they are in their lives, what's important to them, what's on the horizon for them in terms of major family events. To me, it's about getting somebody through what's the next major family thing that you are trying to do or a personal thing that you're trying to accomplish. It may be a wedding, it may be a graduation, it may be the birth of a grandchild, which you and I have been blessed to have a few of those, and so as I've gotten more seasoned and as a clinician for managing patients with ovarian cancer, those things have become ever more important for me, and to understand how what quality of life means to a patient. And so it's important to kind of, that all is very different from one patient to the next. And so it's important to have an upfront discussion about those things and know about patients' lives, to know what's on the horizon for them, and to at the same time, prepare patients for any and all possibilities. So hold out hope and aspiration for control of the disease, control of symptoms, maintenance of functionality, and to live the kind of life they want to live, but at the same time start to prepare them for the possibility or the eventuality that this disease may take them from this world.
Absolutely, and I think I would say to women out there, be honest, speak up, really develop a therapeutic relationship with your physician where you've told them what is most important to you, and they've heard you, because they're really important decisions. And hopefully you feel you have a partner who you can work with in helping to decide what the next steps forward would be. Make plans, plan vacations, and your physician will work with you on that. Anil, how do you approach some of this?
I really agree with the comments that both of you have made. Just a couple of other perhaps things to add to this. One is that the specific situation for a patient, meaning that is their cancer, did it come back after an extended period of time? Did it come back fairly quickly? What types of treatments have they had previously? What their medical condition is like? There are a lot of factors that go into considering, next steps and so on. Here about a year ago, we implemented a program where it's expected that all of the practitioners will address goals of care with patients anytime there's a change in treatment or when they have a new diagnosis or at the time of surgery and so on, just to make sure that we don't forget about many of the important points that both of you brought up. And then the other part that I want to mention is that, in the previous session, we discussed all the new options coming out. Well, that's a good news. The bad news or the tough part is also there are all these new things coming out. And sometimes for patients, it can be very difficult when they hear, well, you have choices of, this. It can be very difficult in terms of thinking through and understanding and making joint decisions and so on. But I really discuss with patients that in a setting of relapse disease, they're part of the team. That a lot of the decisions that we have to make, they really should be made collectively or jointly, where they play a very important part. There's some patients who feel that they just want their doctor to tell them what to do, and it's just we're in a very different period of time. And I feel that it's important to empower the patients and to discuss all the options and then come up with joint solutions in terms of moving forward.
I agree with you wholeheartedly. I think in the last section, we spoke about personalized care and individualized care based on genetics and genomics and molecular characteristics. But these aspects of decision-making are just as important to have individualized and personalized care as well. Your values, your religion, the people in your life, your age, what you want to do. As Ronnie was saying, what goals do you have coming up? What things are really important? And it's okay to say you're tired, you need a break, you need a treatment break, that you want to take some time and have symptoms taken care of. And having your physician, again, trust you, be partners with you, and go through that. OCRA has a program called Woman to Woman, where you can also get paired up with someone else. And some patients find it helpful to speak to another ovarian cancer survivor. But there are programs, support groups that can help you also make these decisions by someone else who's lived through it. And ask your physician, go to the OCRA website. They have information about other support groups, about clinical trials, and they can be a great resource to you. We've mentioned goals of care, and advanced care planning or goals of care is very important. It's part of the key guidelines that should be discussed, as Anil said, at initial diagnosis, at the time of a recurrence or change in care. It's not something that is crepe laid because the end is near. Thinking ahead is something that gives you a sense of control, or could give you a sense of control, to think about what you want and let the people around you know what you want, so that you can maintain your dignity to have your days as well preserved as possible. And I think it's really important to have those discussions initially with your physician, but then also with your family, so that they know what is best for you. I think, Anil, you said you all had a conference recently where we need to be trained as physicians how to have these conversations as well.
Beth, I was just going to make a comment that, that to me, this is one of the most satisfying and privileged parts of my practice, is to be able to walk this journey with patients. Mm-hmm. As much as I get satisfaction at, doing advanced, surgery and providing advanced therapies, I actually get more satisfaction out of walking this journey with patients and and help them emotionally. And I'm sure both of you do the same thing, helping them emotionally and think through this. And it's really no more than really goals of life, right? As much as it's goals of care, because at some juncture we had our goals of life were to get established as in our professions, to get see our kids growing up, see them go to college, and so towards if affected by a disease, we still have those same kind of goals of life, and we can talk through that and manage the expectations of what treatment can accomplish and what it can accomplish.
I agree with you, Ronnie. I think one of the reasons for me, this aspect of walking shoulder to shoulder through the long courses of care with these patients is that not only is there the satisfaction of helping them through difficult decisions, but it's also made me much, very thankful and appreciative every day, and allowed me to live my life more fully. And why I love so much being a GYN oncologist. One other point I think you brought up earlier, but I was going to say, back when we were in training, perhaps in the 80s or so, median survival for ovarian cancer was maybe around 18 months. We never had these opportunities to walk through decade and more with women with ovarian cancer, to help them see births, travel, weddings, all sorts of celebrations. So while the choices and the complexity may have increased enormously as we've gone from one size fits all, our better therapies and the research we've all done, the clinical trials, the collaborations, I think seeing patients live longer. I have patients, I always say 10 is not enough, is one of my cheers. The 10 years isn't enough. We got to go for more than that. And I think we are getting better and better at our treatments. Some of the things, we didn't discuss earlier, we didn't have much time to discuss the role of surgery. Surgery still is a cornerstone for the right patients and patient selection. I think, Ronnie, you mentioned earlier the personal satisfaction we have after doing a complete debulking. But are you still going to the operating room these days?
Well, I don't think as much. I mean, I think we have good evidence to suggest. I mean, I think, first of all, the three of us were really privileged to participate in the Institute of Medicine or National Academy of Medicine effort on the state of ovarian cancer research. And it was eye-opening for me, the things that we, came through with that, in that effort, about how ovarian cancer is not just one disease and it's multiple diseases. And so it was really, again, I keep saying paradigm shifting, but it was for me to think about, as you talked about, a personal approach. And at the same time, we were seeing studies maturing that, suggested that for some patients, primary debulking wasn't nearly as good as, wasn't any more effective than neoadjuvant chemotherapy and interval debulking, and maybe perhaps a little less morbid. So, I mean, taking into consideration, choosing the right patient for a neoadjuvant chemotherapy with an interval debulking approach, I think we've got more insights into that. And again, when we had sort of a primary debulking approach and we had many patients spend many weeks in the ICU recovering, and many maybe months after that recovering from major surgeries, I think we're using the great surgical tools that we have more wisely.
So, Neil, what about in the recurrent setting? If you want to comment, what patients at the time of recurrence might benefit from another debulking surgery?
It's a question that continues to evolve. I think we all would agree at this point that patients who have whose cancer is resistant to platinum-based drugs, surgery really doesn't play an important role in that kind of a setting. But those patients where they have platinum-sensitive relapse cancer, then there are factors that we look at. There have been a number of trials that have come out over the last 5 years in terms of should surgery be done. I think here what we've evolved into is that, if our level of confidence is high, that we can remove all cancer at the time of relapse in a patient with platinum-sensitive relapse disease, then we would certainly consider surgery in that setting. But if there are multiple sites of disease that where the chances wouldn't be that high of removing cancer, then there's concern that with surgery, their outcome may actually be worse. Then in that setting, we tend not to operate in that setting.
And I think just putting a bow a bit on this, our surgical techniques have improved, but so have our systemic treatments. And we've really recognized that we have other ways to effectively treat ovarian cancer with less morbidity. Surgery is still a very important part of the way we approach this disease, but we've just gotten smarter about where our surgical techniques can have their most benefit. Other things, liquid biopsies, circulating tumor DNA, ways that we can make diagnoses. Are you using cell-free DNA at all in your practice at this time, Anil?
As a routine part of practice, no. And I think we would certainly like to learn a lot more about these. And there are some concerns whether these kinds of assays are truly reflective of what's going on in the cancer, or could they be picking up some of the other changes in the body, something called clonal hematopoiesis, or even other changes in the body. I think just like with new treatments, it's an exciting time for these kinds of markers. And, whether it's cell-free DNA, ctDNA, or whether it's looking at exosomes or extracellular vesicles, or many other types of assays that are coming about. But, I feel like that these should be held to a fairly rigorous standard before we integrate these into routine clinical practice. So we tend to build these into some of our trials and have studies, to try to evaluate the accuracy of these kinds of assays, but not for routine practice at this point.
Ronnie?
No, I agree with Anil. I mean, I think, we're getting better and better at being able to measure molecular processes. What we need to have moving forward is, how what we measure impacts what we do, and how that impact may either positively or negatively affect the patient's outcome. And so that's the dots that we have to connect. And so it's great. I mean, you just think about it. The DNA structure of DNA was diagnosed, 70 years ago or 60 years ago. And now we're doing so much sophisticated DNA analysis that it's incredible to think what's happened in a very short period of time with less than the most sophisticated technology, but to think of what's going to happen over the next 25 to 50 years in our ability to measure the molecular events real time. And I think it's really an exciting period to be able to do the studies that will help us show how that will affect our treatment decisions for patients, and how it will affect their overall their outcomes in the long run.
Yeah, I agree. It's not part of my standard of care either, but I am optimistic that it will be part of the paradigm we use. We've seen it in breast cancer. I mean, ovarian cancer, as we know, is not necessarily mutation driven, but more having copy number alterations and other things. So some of the tumors where circulating tumor DNA has become part of the paradigm of looking at response, perhaps can inform how we move forward. The one place where I found it helpful, again, getting back to our BRCA patients, since we know that some patients whose tumors may be driven by a BRCA mutation, and that mutation undergoes reversion back to a state where it's no longer mutated, some of that times that can be picked up in a blood sample where patients don't need to go through another biopsy. But I think that it's still something that is ongoing into the future.
There are really some exciting studies looking at either like de-escalating therapies with using circulating tumor DNA and in other solid tumors. And so maybe there'll be opportunity for us to mimic some of those.
And I think, we've had trials this year we mentioned earlier that shows more is not necessarily better. We don't need to keep going on with our anti-angiogenics. That there really are ways to stop treatments and reduce morbidity from that. Before we move on to some other tumor types, with our quality of life things, I do also want to mention things, there were questions around diet, exercise, stress management, and they're all important. Anil, you've done so many of the seminal studies on stress and cancer recurrence. I don't know if you want to mention that for a moment. I think that would be helpful.
Sure, be happy to start, and then please feel free to add in as well. We know that chronic stress, and a lot of people, when we talk about stress, they view it very differently. So I want to be clear that when we talk about chronic stress, this really some examples would be actually caretakers of people who have chronic illnesses. That would be one example of chronic stress. Or those that have major distress or other psychologically defined terms. That's where there is some thought that it could impact on how their cancer grows and perhaps response to therapy and so on. And there have been a number of studies done over the years in ovarian and in other cancers where such concerns have come up. I'm a huge advocate for, number one, assessing this in patients. I feel like, that there really should be absolutely no stigma in talking about mental health and also the impacts of stress in an individual's life. And then moreover, there are many ways to address these. And it doesn't mean that just as a practitioner, we just have to prescribe a medication. I don't think it's that simple. So I really believe in, engaging our psychology colleagues. And they have a number of techniques and methods ranging from, whether it's biobehavioral interventions such as meditation or cognitive behavioral therapy and so on. And then, if it's something where there's major depression that's persisting, where, pharmacological or medication type of interventions are important, then obviously working with our psychiatry colleagues in that kind of a setting as well. But perhaps the point that I could emphasize the most is that, mental health, really, there should be absolutely no stigma. I actually encourage patients to bring up any concerns so that we can address them proactively rather than being reactive around those.
I agree. Having a holistic approach to the patient's life. They're not just an ovarian cancer patient. They're perhaps a wife, a mom, a sister, and those added stresses of the people around them really can impact their cancer. And it's important to discuss those aspects with your physician who, Ronnie, we all were saying we walk along with them through these journeys to address those things to help them live better. Ronnie?
Yeah, it really, we have a saying around here that there's no health without mental health. And so I think we used to be very siloed into the cancer and the cancer treatment. And now we think about genetics and hereditary risk. We think about management of cancer-related pain. We think about more and more, we need to think about the sort of the mental health side of this. And it really takes a village, as Anil talked about it. We as individual GYN oncologists can be good at some of this, but we can't be good at all of it. And so we have to have readily available resources to be able to refer our patients to help them manage those things when they get beyond the scope of what we can help them with. And it does really take a village of psychologists and supportive care people. It takes families, and it takes friends and churches and social groups, et cetera, to really help support people and get them through which is the world is full of a lot of stressors, particularly at this time with COVID and the million other things that are going on. So and cancer just adds another, it's a whole new level in and of itself. So it's really important to take advantage of those a village of people that can help you with this, both professional and family and friends.
let your doctor help you navigate to get to those resources so that you can live your best life possible. I'll just mention that during the conference, there are also on-demand sessions with on nutrition with a registered dietitian from Johns Hopkins, as well as sessions on advanced care planning, so that these are just important aspects that the OCRA conference can provide to you as well. I'll shift gears for a second. There were a number of patients who had questions with regards to rare ovarian cancer tumor types. And we can go into this some. There will be a whole session that Rachel Grisham from Memorial Sloan Kettering is going to have on rare ovarian cancers. But perhaps we can start with treatment for low-grade serous ovarian cancers, an unusual cancer. But there were a number of questions as these women live longer, talking about some of the emerging treatments and the ways we think about low-grade serous cancers. Neil, do you mind if I go to you first, since so much of this work has come out of MD Anderson?
Thanks, Beth. And I'll start, and please feel free to add in. So, one of my partners, Dr. Gershenson, has really championed the distinction between low-grade and high-grade serous cancer, and then also, how to more effectively treat the low-grade serous cancers as well. These cancers, low-grade serous cancers, represent about 10% of serous cancers, so they indeed are uncommon. And we've learned that that not all chemotherapy drugs that we typically use for patients with high-grade serous cancer, they don't work as well against low-grade serous cancer. There are a couple of drugs that still have activity, but certainly nowhere to the extent that they work in high-grade serous cancer. Where we've seen perhaps the better responses in this setting have been with drugs that target what we call hormonal pathways. And to be more specific, blocking the estrogen connection to these cancers, so they don't have access to estrogen. So either using drugs that block estrogen production, or even the receptor for this kind of a hormone, blocking this on cancer cells. These have certainly been active. Then we've learned, we talked a lot about personalized medicine earlier and checking the tumors for mutations and so on. So it turns out that low-grade serous cancers have a very different mutation profile. They tend to have mutations in a gene called KRAS or BRAF, much more commonly than other types of mutations that we see in high-grade serous cancer. And as a result, one of the large-scale clinical trials that was finished not too long ago, and the results were presented last year, it actually showed that a drug called trametinib, which falls into this category called a MEK inhibitor, that has a good amount of activity against this type of cancer. And so we're certainly using a lot more of that drug. And again, this is where testing the tumor in patients who have low-grade serous cancer, it's certainly valuable in terms of considering treatment options. Then also drugs that target the blood supply, we've already talked about it, bevacizumab. Well, that does have activity against this cancer. In this setting for low-grade serous cancer, a lot of times we'll actually start with just using bevacizumab alone when we're going to use it, rather than even combine it with chemotherapy, and then we will add the chemotherapy drug later if need be. So there are different classes of drugs that have shown to be active against this tumor type. A lot's been gained. There are now really interesting clinical trials that are ongoing. Some of this we've learned from the breast cancer setting in terms of what drugs to use, but there are certainly really interesting clinical trials that are ongoing, both in the upfront and in the relapse setting.
I think, again, as it's a rare tumor, or at least uncommon, participating in clinical trials, seeing experts, women with low-grade serous cancers live much longer. But it's important to keep those tumors under control as well. And the hormonal pathway approach, even as a maintenance therapy after primary treatment, can delay recurrence, and very important to discuss with your physician. Ronnie, do you want to say a few words about mucinous ovarian cancer? I'm not trying to give you a tough one, but mucinous ovarian cancer is at least differentiating it from gastrointestinal tumors and how one might approach if they had a mucinous tumor.
Well, most of the mucinous tumors in the ovaries tend to be larger tumors, and they more often present as earlier stage than compared to maybe high-grade serous carcinomas. We certainly need to be cognizant of whether or not a patient has any evidence of a GI tumor. So it's having a EGD and looking into the stomach and looking in the colon to make sure there's no occult cancer there, and that the tumor that you've recognized at the time of surgery doesn't represent an intestinal metastasis is important. It's important to look at the appendix. That's sort of the first thing that's important about these tumors. The second thing is they tend not to be as responsive to Taxol and carboplatin as the high-grade serous cancers are, and maybe some of the other ovarian cancers are. So we explored using some of the chemotherapy regimens that are commonly used in intestinal tumors. And so you'll see on the NCCN recommendations, both regimens are present there. And actually, I think many institutions will actually consider utilizing the oxaliplatin and 5-FU regimens that are more commonly used in intestinal tumors. That said, this group of tumors tends to be somewhat resistant to chemotherapy overall, and it's important for us to, as much like we were doing in low-grade serous cancers, understand the unique molecular biology and explore utilizing new agents that may target some of the molecular events that occur in mucinous tumors that are more often, as Anil said, sometimes in low-grade serous cancers, focused around KRAS and other types of things that are commonly seen in intestinal tumors.
Yeah, no, I agree 100% with what each of you said. The only other thing I'd add, Ronnie, since we haven't really touched on it, is the use of HIPEC, or heated intraperitoneal chemotherapy, which sometimes, again, may be used with mucinous tumors, where at the time of the surgery, if all the tumor can be removed, the platinum agent or other chemotherapy agent is in a heated fashion is placed in the abdomen, and the surgeons rest for a little while and then removed, and the surgery is completed. And that while in high-grade serous tumors, that approach has not been shown to truly improve survival, in some of the GI and mucinous tumors, folks are looking at HIPEC as another approach. At least that's what we're doing here, right? Are you guys doing HIPEC where you are too, at least in some situations?
So for patients with mucinous subtype, absolutely. Yeah, that's certainly something we would consider as an option in the overall, grouping of treatments. Yeah.
Yeah.
And I think we're the same way. There is going to be a new trial that's being developed through the cooperative groups to the GOG Partners mechanism, I believe, that will be investigating HIPEC in, I think, a randomized controlled trial fashion. And so there's been some promising, studies that have shown some improvement in progression-free and overall survival. And so it just needs to be confirmed, and making sure that we look at it in the context of utilizing all the systemic therapies that we have available now, particularly with the PARP inhibitors.
I think it really does need a prospective randomized control trial, because centers that do it routinely do quote benefit, but I think it needs to be looked at in a context in a randomized control fashion. The other tumor type that there were a lot of questions around were granulosa cell treatments. Granulosa cell tumors, again, an unusual tumor of a different type now. It's not an epithelial tumor of the ovary. It's, of course, a stromal tumor of the ovary. Has, again, a different molecular profile, of course, than what we've been talking about. We mentioned the high-grade serous tumors and BRCA and P53 mutations being so common there, and possibly things to think about targeting, and the RAS mutations in the low-grade serous and the mucinous. Granulosa cell treatments often have something called tumors, often have a FOXL2 mutation. I don't know, I'll ask you, I don't know of anything that targets that mutation. I just know of it as something that we use for diagnostics. Are you guys aware of anything targeted?
Not at this point, no. I think it's more as a pathognomonic mutation
Right.
for adult granulosa cell tumor, right?
Yeah, that's, I tried to, look into that, but I think again, so often we do go back to our chemotherapy, perhaps adding in Avastin or bevacizumab, because it often does have many blood vessels within it. And again, the hormonal pathway that you spoke about is, again, may be very useful. But granulosa cell tumors, similar to the low-grade tumors, often have a longer course with later recurrences, where patients, will be seen over and over years. Tumor markers can be things like inhibin, not just CA125. So making sure you have the right tests being done at the right times. Ronnie, you were going to say something?
I was just going to say this is an area where I probably more commonly utilize secondary and tertiary and beyond surgical resection. And so it's not uncommon to, operate on somebody with a granulosa cell tumor
3, 4, 5 times.
3 to 4 or 5 times. And so it's where we talked about it's not so practical in maybe the epithelial tumors that we more commonly see. This seems to be an area that, I've grown up with patients, that
Decades.
were young when they had it, and now, their kids are in high school and about to go to college. And so
I think seeing those late recurrences, even 20 years later, the biology of this tumor is different in terms of its mode of spread, which is why I think these surgeries spaced out can really improve overall survival.
Patients do at some juncture get into a position where surgery is not feasible any further or more subject to a lot more surgical risk and complications. And so that becomes a challenging time. But for the most part, I think there are several, over a decade, you can probably manage many of these patients with repeated surgical exercises.
And, hormonally targeted drugs certainly have been valuable in this setting. Here we started we call a rare tumor clinic. So I'm certainly seeing a lot of patients with granulosa cell tumor now. And, even in a maintenance setting, I'm certainly starting to use either a drug like letrozole. And then lab setting, again, these are right now anecdotal experiences. We're actually going to look at these more formally as well. But a drug like Lupron certainly has, seen really, really nice responses that at times have persisted for quite some time. In a fraction of patients. It doesn't obviously work in everyone, but these hormonally targeted drugs certainly have a really important role, I think, for this tumor type.
Absolutely. And I think since these women do live so much longer, remembering holistically, like we were talking about earlier, thinking about bone density and the other impacts of being on the aromatase inhibitors for long periods of time. Unfortunately, I've seen patients live quite long, but I've also seen them have fractures and other things that could impact their lives. So I think seeing someone who is at a center where they have some expertise, the importance of getting second opinions, and really being honest with your physician as they can be honest with you with your questions and concerns. There were questions about tumor types that we may not consider rare, but perhaps we can better educate everyone about. And that was, how does fallopian tube cancer and primary peritoneal cancer fit into the paradigm of treating ovarian cancers? Ronnie, you mentioned the Institute of Medicine National Academy report, and I think that we really did discuss this a good deal there. I don't know if you want to expound on that for us here a moment.
Yeah, I think what's the story of, ovarian cancer, and particularly high-grade serous cancer, is really fascinating to me, because you think about it, back again, when some of us were training way long ago, we didn't think people were at genetic risk for developing ovarian cancer. And then, we have some, very incredibly smart people isolate the BRCA genes. And then we start doing risk reducing salpingo oophorectomy for patients. And then we have the insight to see that a fraction of patients have these high-grade serous tumors, but they're not starting on the ovary, they're actually starting in the fallopian tube. And there was epidemiologic data to suggest that if you had a hysterectomy or you had a tubal ligation, you reduce your risk of ovarian cancer. And I always used to think like, well, that doesn't make any sense to me, because I was in this paradigm that all ovarian cancer starts from the epithelium on the ovary. And so I think that's just a fascinating story to have lived through, and to understand now that, again, as we've we're more of splitters than we are lumpers. And when we look at this group of patients called high-grade serous carcinomas, and we think about them as that the fallopian tube is this, it's an open access system and subject to a lot of inflammatory cytokines from either menstruation or environmental exposures, et cetera. So it's like many of the different areas of the body that have these transformation zones a little bit, where cells are subject to these environmental exposures and natural pathogens within the body that actually can cause mutagenesis or transform a cell from normal to abnormal. And I think, to me, majority, that's why we see with high-grade serous carcinoma, I think, such spread of a lot of a disease everywhere, and oftentimes very small ovaries, and not the big ovarian masses like we see with endometrioid cancers or mucinous cancers or clear cell cancers, because the origin of the cancer is not in the ovary, it's in the fallopian tube. And it's interesting, and you'll hear probably the screenings about the screening studies, and the large studies like PLCO and the UK tox study mainly were screening the ovary. So we were maybe missing the organ that we should have been looking at, so that's a very fascinating story.
Yeah, I think the native serous epithelium that undergoes cancer transformation is what's normal at the end of that fallopian tube.
Right.
And there's just a ton of it at the end of the fimbria. And as you said, there's toxins from retrograde menstruation of some of the blood coming up and out the tube, but also there's great oxidative stress placed on those serous cells at ovulation. And all those enzymes and cytokines and factors that are released when one ovulates, that the tube sort of jumps on the ovary and has those toxins, and it causes it to have gene damage, genotoxic damage. And if there's a BRCA mutation you've inherited, you're even set up to accumulate those changes even more. So I think that tubal cancer, ovarian cancer, primary peritoneal cancer are these high-grade serous cancers and are really treated the same way. One of the things we discussed at the conference you were talking about earlier is that most ovarian cancers probably don't begin in the ovary. Right. As serous cancers likely begin in the tube. Endometrioid cancers likely begin from endometrium or endometriosis that got outside of the uterus. Mucinous tumors may begin in either the GI tract or, perhaps cervix, but really it's the low-grade serous cancer that may begin in the ovary, but most of the ovarian cancers likely start someplace else. But the ovary seems to, it's a bad pun, to be a fertile ground for the cells to stick on with all its blood supply and its growth factors as the egg's maturing, that's where the tumors seem to grow. But we do have an opportunity now to think about ovarian cancer. It's not just one disease, and we have tools and information now to really treat it as an individual. Anil, do you want to talk at all about prevention, since we know that the most of these serous cancers, the most common type, begin in the fallopian tube, and some of the new thoughts about preventing ovarian cancer?
So I think, Beth, what you're bringing up is, whether it makes sense to remove the fallopian tubes at some point, and whether or not that truly will decrease the incidence of ovarian cancer. There are a number of studies that are ongoing that are looking at this question, and we certainly look forward to answering this. And it's a really important question to answer, because if we can reduce the incidence, or if we can reduce the risk for ovarian cancer and preserve ovarian function so that we're not putting women into menopause at a younger age, boy, that would be incredibly powerful and valuable. So we really look forward to seeing the results of these studies that come out. So far, in terms of feasibility of being able to do these kinds of studies and so on, I think that exists at this point. We've learned that, but whether or not they result in clinically meaningful results, that'll just take some time to know for sure.
I think we have a large epidemiologic study ongoing that should result out soon. And then the cooperative groups, of course, have a prospective study to look at it and look at the incidence of it. But we can say that the American College of OBGYN and the SGO have recommended, when you're doing a hysterectomy, to remove the fallopian tubes if possible, that the fallopian tubes are part of the uterus really, and that to be doing salpingectomies when you're doing a hysterectomy, even for benign indications in a non-BRCA carrier, that salpingectomy should be part of that surgery as well. At least that's what we're teaching our residents now, and putting it forward that the fallopian tube is part of the uterus, both embryonically and throughout, and that you don't need to take the ovaries out, and that they do appear to have normal function after the tube is removed. So something else to do. So I think that those are some of the important things. There is going to be a session on the large screening trial that was done in the UK by the leaders of that trial, Usha Menon and Ian Jacobs. But there were some questions with regards to the use of these multi-cancer screening blood tests that look at different platforms that we know are beginning to be marketed now. You have one test and it tests you for all cancers. And do we think those might be good for ovarian cancer? Have you guys had experience with ordering any of these tests yet, or participate in those trials?
I've not. I mean, I think, again, it gets back to the fact that we have the technology to measure a lot of different things. And what we have to worry about is both sensitivity and specificity when we do apply these on a population basis. And on an individual basis, what's the positive predictive value and the negative predictive value. So I think what we have to be careful about is that we may subject people to a lot of intervention on the basis of some of these tests, which may be falsely positive, and we can do some harm. And we actually saw some of that in the traditional study, like the PLCO study that just looked at CA125 and sonar alone. And then, ultimately, we could lead to some harm, but that negatively affects people's outcomes and may not reduce the mortality related to this disease.
And I agree with you. Again, I think all of us have been around this block so many times, but it's normal to be, to have fear of getting cancer and fear of ovarian cancer whose symptoms exist but are not specific. And there have been multiple tests put out there before, proteomics and different tests that were sort of brought to the survivor community before real scientific rigor. And we do want to be careful. So I think there are some exciting tests that are being studied, looking at different markers. But I agree with you that we need to have more data specifically on ovarian cancer patients, as they are a pan-cancer test. And we want to make sure that they have both the specificity and sensitivity to improve survival. And
the best thing we could do right now, Beth, is to tell our audience, know your family history. And if you have family history suggestive of, with multiple cancers, particularly in first and second degree relatives diagnosed at a young age, then that's important to go get genetic testing. And for those of you who may already be affected by cancer, it's important, as you said earlier, to get, genetic testing and to be able to, if you do harbor a mutation, get your family members tested. So, because the best way for us to try to reduce, we could probably reduce the numbers of people that get high-grade serous cancer by 15 to 20%, which is not an inconsequential number in the United States, by just merely doing germline testing. And there's so many people that aren't, that have not been tested. So I think it's an important point to emphasize here when we're talking about a blood test for screening.
It's estimated that about 90% of the individuals in the US who carry a BRCA mutation don't know it till someone in the family gets cancer. And I think knowing your family history, discussing it with your physician, having counseling and testing so you get the right test done. And then if you are found to carry a gene, to talk about it. Thanksgiving's coming up. Tell the folks in your family. I do want to caution folks about doing it in a medical format, that things that you may do like Ancestry.com and 23andMe don't provide you the depth of testing that you would have with a test that's meant to do germline genetic testing in a medical format. And it's really important to get that important result that's right for you, for your ethnicity, and for your own family history, to make sure that you don't have even false reassurance that that test is negative when indeed it's not the right test for you. The other thing I'd say with COVID and the opportunities of telemedicine, that a lot of the genetic counseling and testing can be done via telehealth visits. And you can even do the cascade testing with your family in a given telehealth visit and bring them into the screen. And I've done genetic testing, genetic counseling sessions with 6 members of a family in different states. And the testing that can be done based on a saliva kit is just as good as a blood kit. So we can mail the saliva testing kits to your home and you can return them, and then we could follow up when we have results. So it's become less invasive, easier to do. And as Ronnie was just saying, you can help, best Christmas gift you can give to your family members is to help save their lives. And remember that while we're here today talking about ovarian cancer, and genes like BRCA have been called the breast ovarian cancer gene, men are just as likely to carry these genetic mutations as are women. And we know that the BRCA genes increase the risk of prostate cancer and pancreatic cancer, where PARP inhibitors have been shown to be very effective. So again, having the men in your family who are blood relatives also have the genetic testing could impact their risk of cancer, and if they have cancer, can impact their treatments as well. So it's really powerful information for all of you. Any other last words? I think we're at the end of the hour once again. It flies by so fast.
I'll just say that I tend to be an optimist, and I'll just say, I actually track numbers of, incidence and mortality and how many women are living, on an annual basis. So one of the questions I think that we have to challenge ourselves with is, are we making progress? And I would say that in the last, 20 years, year over year, we continue to make progress. So I think that there have been a lot of advances that are really powerful. That doesn't mean that we're done. We obviously have a long ways to go in terms of improving cure rates and so on. But I do think that it's a really exciting time in terms of all the new advances, whether it's in detection, prevention, treatment, survivorship, and so on. And I think we're just going to continue to see this pace increase or accelerate even further. Thank you.
Yeah, I would agree with Anil. This is really an exciting time. I would also, first of all, like to thank the OCRA for the privilege of being here and working with these two great friends of mine and exceptional scientists and clinicians. But I'd also mostly like to thank our audience for your advocacy and for your participation, because really we can talk all we want to, but if we didn't have the power of your voice, we wouldn't get the funding that we need to be able to do this type of research. And so I urge you to keep your voices elevated and tell the stories of success that we've had, and hold one another's hands as we walk through sometimes the challenges and failures. But it is still a better day today than it was, yesterday and many years ago, for sure.
I think you guys have said it perfectly. I too am an optimist. As I said earlier, it's the most exciting time that I've been a GYN oncologist, because year over year we are seeing new discoveries to allow women to live longer. The community is strong and able to come together and speak out, and have learned how to be better advocates. And the only other piece I'd add is we're training new GYN oncologists who are smarter than we are, who are even going to bring new therapies, new approaches, things we couldn't even get to today that maybe next year we can talk about, of other ways to target the ovarian cancers to really aim for cure. I do want to thank the Ovarian Cancer Research Alliance for all of their work for ovarian cancer, for leading the field in this way, and for allowing us this opportunity to speak with the ovarian cancer survivor community. We are part of you. We feel part of this community, and we'll forge a better path forward together. So thank you very much. No matter what city you're in or what time zone, we're thrilled to see you, and hopefully in person next year.